My name is Kelvin Chin, clinician scientist and senior consultant from the National Heart Centre, Singapore. In this session, I will be discussing the role of exercise stress CMR. This is a novel area in stress imaging that is developing and gaining a lot of interest in the CMR community. The primary role of stress testing is to diagnose ischemia and significant obstructive coronary artery disease. A brief understanding of the ischemic cascade is therefore informative. In early coronary atherosclerosis, perfusion abnormalities can occur without ischemia. With progressive stenosis, oxygen supply-demand mismatch becomes more apparent, resulting in myocardial ischemia. This can be manifested as regional wall motion abnormalities, ECG changes, and in more advanced stages, symptoms presented by the patient. These manifestations can occur with stress or at rest, depending on the severity of the disease. The assessment is based primarily on two principles. Number one, inducing hyperemic response, either directly with vasodilating agents or increased perfusion from exercise and dobutamine stress. Alternatively, you could induce ischemia through oxygen supply-demand mismatch with exercise or dobutamine stress. The manifestations can then be detected using a variety of cardiac imaging, such as nuclear, echo, and cardiovascular MR. Theoretically, CMR has the strengths of detecting both perfusion defects and regional wall motion abnormalities. There are obvious advantages of exercise stress testing. It is a physiological way to induce ischemia. Exercise parameters such as blood pressure, heart rate response during exercise, and recovery have incremental prognostic value. Exercise stress CMR has potential challenges. Conventionally, CMR is done with patients holding their breaths so as to minimize breathing motion artifacts. This can be challenging or somewhat difficult to have your patients hold their breath and exercise at the same time. There are, however, free breathing imaging sequences. However, up until recently, these sequences lack adequate spatial temporal resolution. More importantly, we don't want any unpleasant accidents like this with your exercise stress equipment in your MRI unit. In fact, exercise treadmill CMR has been around for a while. The first studies were conducted with the treadmill outside the scanner, and later MR-compatible treadmill, such as this one from OSU, has been used. Early experience with MRI-compatible exercise treadmill demonstrated very good diagnostic accuracy for significant coronary artery disease. Of note, ischemia in this study was defined as reversible perfusion defect with or without regional wall motion abnormalities. As highlighted, there are certainly advantages of exercise treadmill CMR. It is a physiological stress modality, and we can monitor ECG changes during exercise. Studies have shown excellent diagnostic accuracy and short-term prognostic value. There are some trade-offs. With exercise treadmill CMR, we can only image at peak exercise, and there is a short delay in transferring patients from treadmill to the scanner table. They may reduce the sensitivity of detecting ischemia. Other centers have developed exercise stress protocol using supine bike ergometer. The advantages are image acquisition using free breathing sequences can be performed at every exercise stage, minimize delay in transferring patients, and at our center, using the supine bike ergometer, we were able to achieve adequate spatial temporal resolution visually. What are some of the potential clinical applications of exercise stress CMR? I will illustrate using the following examples. The first case is a 24-year-old male who was referred to our center for suspected dilated cardiomyopathy. He had no family history of cardiomyopathy and sudden cardiac death. He claims that he exercises about 3 hours a week in a gym and plays basketball regularly. Rest-based CMR showed mildly dilated LV with mildly impaired left ventricular ejection fraction of 47%. Right ventricular size and function are within normal limits. No fibrosis was seen on late gadolinium enhanced imaging. In the second case, a 20-year-old male who claims to be very fit, plays football and exercises regularly in a gym as well. Like the first case, there was no significant past medical history or any family history of cardiomyopathy or sudden death. And also like the first case, his rest-based CMR showed mildly dilated LV with mildly impaired LV ejection fraction of 40%. RV size and function were normal, and there was no fibrosis seen on late gadolinium enhancement. So now the question is, who had an abnormal scan? What we did was that we put both patients through our exercise stress protocol. Using our recently published normal exercise capacity, case 1 was able to achieve an exercise capacity more than 90th percentile for his age, while case 2 was only able to achieve an exercise capacity of 50th percentile for his age. With exercise stress CMR, we are now able to differentiate exercise-induced cardiac remodeling from early dilated cardiomyopathy with greater confidence. In the beginning of the lecture, I did mention about the role of stress imaging in diagnosing coronary artery disease. Early experience with exercise treadmill also showed very promising results. What about with exercise stress using supine bike ergometer? This is a case of a 57-year-old male who was a heavy smoker and a history of dyslipidemia, hypertension, and diabetes. He was referred for exertional symptoms suspicious of angina. He underwent exercise stress CMR on the supine bike ergometer. With exercise stress, the inferior septum and inferior segments appear hypokinetic. At peak exercise, there was also evidence of reversible stress defects seen in the inferior segments. On late gadolinium enhanced imaging, a subendocardial infarction was seen in the inferior and inferolateral segments. Lastly, the patient was only able to achieve an exercise capacity equivalent to 6th percentile for his age. The patient subsequently underwent invasive coronary angiogram, and that showed significant stenosis in the right coronary artery. And this corresponded to the abnormalities that we saw on exercise stress CMR. This case highlighted the ability of CMR to assess coronary artery disease using 4 different approaches: detection of ischemia from regional wall motion abnormalities and perfusion defects with exercise stress, detection of myocardial infarction with late gadolinium enhanced imaging, and lastly, assessment of exercise capacity. In summary, exercise stress CMR is evolving and has a huge potential as a stress modality to assess regional wall motion and perfusion defects using the same modality. Future studies are needed to validate the diagnostic and prognostic value in various cardiovascular conditions. With this, I thank you for your attention.